There's this photo on the desktop which says Medicine X. And
Oh,
there,
thank you.
maybe it's in there.
It's a team effort.
Hi everyone, good afternoon. Today we are going to be talking about pre and post-op pain and how we can use integrative medicine for this. I'm very excited to have a great panel here with us. We have Alicia, e-patient advisor here at Stanford, Pat, who's a clinical psychologist, Jesse, who's an internist here at Stanford, and we're super excited to have Dr. Greenstein join us, who's the CTO of HHS. So we're going to start with Alicia, which is going to tell us her story, and then we're going to go into the science behind it. We're going to talk about the practical aspects of pain management and research, and then we're going to, at the end, close with Dr. Greenstein talking from policy perspective. Oh, sorry, Greenstein talking about policy.
All right, good afternoon. My name is Alicia Staley. For those of you that have not met me yet, I'm actually the e-patient advisor for this year's e-patient scholars program here at Medicine X. So over the last few weeks, I've been working to bring the next generation of e-patient scholars into the Stanford, into the community. So it's been a wonderful experience for me as somebody that's participated here for almost 6 years as an e-patient to see a new crop of e-patient scholars making their way into this community in a way, hopefully that will continue to help shape policy and healthcare direction moving forward in the next couple of years. I am a 3-time cancer survivor. I was first diagnosed with cancer when I was 19 years old. I had Hodgkin's lymphoma and went through 3 years of treatment to actually finally be able to be free of the Hodgkin's. I had radiation, chemotherapy, and a number of surgeries. And so that was really my first touch point with pain, the experience of pain from surgery. And unfortunately, that wasn't the only point where pain intersected my cancer survivor story. I was diagnosed with breast cancer in 2004 and again in 2008. And between 2004 and 2008, I learned a little bit more about pain management or understanding pain, ways to approach pain that I had never thought of before, didn't know that was available to me. So when I was treated for Hodgkin's in the first surgery for breast cancer, the idea of treating pain was there's medication that you can take. There's pain pills, there's medication, there's in some cases morphine drips that you can take to help alleviate the pain, but I never felt like that was really addressing the core root of how I was feeling. And there was something about taking medications to sort of mask the pain symptoms that really bothered me. didn't quite understand. And the pain got so bad, actually, when I was going through radiation for the breast cancer, that I actually considered stopping my treatment and walking away from the radiation protocol that I was enrolled in, because I just couldn't handle the amount of pain. My skin was burning. I was having skin failure. In some cases, not to be overly, not too gross about it, but it is what it is. And I was dealing with significant amounts of pain. The pain was not only physical, but it was mental. And I was having a hard time really staying focused and trying to get to the end of the treatment cycle, the amount of pain that I was in. But I stuck with it, was able to finish the treatment, but unfortunately, that really left a real negative feeling for me that, that pain for me was very scary. It was uncontrolled at the time, and I just felt like no patient should have to live like this. In my experience, I think from learning a lot from my friends in the chronic pain community, that my pain was what I like to call little pain. There's little pain and big pain. My friends in the chronic pain community deal with big pain all the time, and I just couldn't believe what they have to deal with. But when I was diagnosed with breast cancer a second time, which was my third cancer diagnosis, I was facing a bilateral mastectomy, and I knew that I was going to be in for a major surgery with the potential for pain again, and I really approached it very differently. I wanted to do some prep work in true e-patient form. How could I prepare for the surgery ahead of time and understand or just brace myself for the potential pain? So I approached it thinking there's got to be a way to prepare myself to be ready for pain. And I found a book, and I wish it was up here, but I'll tweet out the link. It's called Prepare for Surgery, Heal Faster. And I see some people nodding their heads. It was a book by Peggy Huddleston. She's based in the Boston area. And I used that book almost like a workbook leading up to my surgery. And it talked about things like writing out your affirmations for your surgery. And at first I thought it was silly, because I'm an engineer, so I was thinking, is it really possible to write your way through your cancer pain experience? And I thought, you know what, I'm going to give it a shot, because I really started at the end of my rope. I did that. I wrote out my surgical affirmations, and my affirmations included really positive thoughts about getting through the surgery and waking up from the surgery pain-free, for thinking and visualizing that I was going to wake up from my surgery in a better state. I woke up from the surgery and wasn't even thinking, or wasn't in any pain at all. Wasn't really thinking about it. And as you can see, I wear glasses, and I was in the recovery room, and the glasses, I could see my glasses out of the corner of my eye up on a shelf. And without even thinking, I reached up. And I had just had my bilateral mastectomy. I reached up and grabbed my glasses, and the nurse was standing at the foot of my bed. She's like, what are you doing? I said, I can't see. I need my glasses, so I'm going to get my glasses. Put my glasses on. She said, I've never seen anybody do that within minutes of coming out of their bilateral mastectomy. She said, did that hurt? I said, actually, no, it didn't. I didn't feel any pain, and I'm sure I was still sort of hopped up on medication that they gave me during the surgery. But I started, from that very moment, thinking, wait a minute, maybe my affirmations worked, or maybe the prep work that I did in the weeks leading up to this moment, or this surgical moment, was really going to have a positive effect on me. So of course, in true e-patient fashion, I was staying very tuned into what I was feeling, and was I feeling pain, how I could sort of talk. Can I talk myself through pain? Can I dialogue in my mind about what's going on? And it was a very telling experience for me, because every moment where I thought I was slipping into what I would consider either uncontrolled pain or a really heavy-set incident of pain, I was able to stop, take a deep breath, and sort of refocus my mind and refocus just my energy on where I was. And sort of, I taught myself through this book how to calm down and sort of brace myself or, prepare myself. And as an engineer, it was very hard for me to wrap my mind around the fact that I could do this, that I could lay in bed, take a deep breath, and really center myself in a way that allowed the pain to either, move through my body, or I was able to stay ahead of the curve, where I could ring my bell and ask for Tylenol. I felt the need for something like that. And the nurses on my team were amazed because I never requested any pain med other than a Tylenol the very first night that I was recovering from that surgery, and never took a pain med in the weeks after that. Even as I was going through rehab, I went through rehab to basically regain my arm strength. And they have always watched that as sort of this test case of, can we really use this mindset training, or use this book to help patients through their journey. And enough of the nurses at Tufts Medical Center sort of watched my experience through this, that now every year I donate 100 books to the hospital. So anybody that's going through surgery has an opportunity at least to read this book. And my surgeon now actively works with other patients on writing affirmations. And he was, and I hope it's okay that I can say this, but he was a very old school doctor. So when I came to him with the idea that can you please read these affirmations with me as you're putting me out under anesthesia? He was like, he's like, all right, I'll try it once. Let's see what happens. And we talked a number of times after my surgery, and I convinced him that this was something that he needed to do. So he now does surgical affirmations with his patients leading up to surgeries. And I got to see him this year at the American Society for Breast Surgeons conference. I was actually speaking at a conference. I didn't know that he was going to be there, but he came up to me right afterwards and said, I give all my patients the book, and we still do surgical affirmations, but he said, I remember that your last affirmation is still the best affirmation I've ever seen on anybody's sheet. And I said, oh yeah? I said, you remember that? And he said, yes, I do. The last line I put on my affirmations was, I will be able to outdrive my brothers when we play golf by at least 50 yards, and I still can. So it's a victory for all of us. But anyway, so that's my story. I'm going to turn it back to Sangeeta, just with the thought that there's patients out here, there's patients out in the healthcare system today that are anxious to work through pain in ways that they might not have been able to do before. So if you have a patient that approaches you with what might sound like a crazy idea, give it a shot, because you never know where it will take you. So thank you for the opportunity to share my story.
Thank you, Alicia. Now, Pat is going to talk about the psychological impact of pain.
Hi, everybody. Good afternoon. Thank you so much for joining us today. We are delighted to be here. We appreciate you taking your time to share this session with us, and it's an honor to be here with all of you, so thanks for coming. It is very, very hard, Alicia, to follow up any discussion of psychological factors after what you just talked about. So thank you all. It's been great. Anyway, the reason that I wanted to share a little bit from my perspective about psychological factors was that not everybody is as forward-thinking and has the kind of support system that you've created for yourself, which is really unfortunate, but it is true. I think Alicia's story really does help us identify the fact that her work, her travel, her journey has been very patient-centric and patient-focused, and you made that happen, for sure. And people were willing to go along with you, even your surgeon, which is great. And he's moving forward with what you've done before. That's my issue as a psychologist. I want this to be patient-centric always, because it's very, very easy for things to become cookie-cutter. A knee replacement is a knee replacement. Well, it may be the same surgical procedure, but the patient is different and the patient's life experiences are different. Also, you talked about lots of biopsychosocial components. If you do lit search, in many cases, you're looking at pain management, but the material that you're looking at is what medication you use. It really doesn't integrate the biopsychosocial sort of complex as a whole, which I think is really critical, and I think is borne out in this discussion. So I don't know if you can read this, but I thought this cartoon was cute, especially in light of some of the things that go on today. It says, any pain today not caused by, forgive me, the government, greedy corporations, annoying celebrities, or society in general. And I think this is very apropos because these are many of the things that people have to deal with, just dealing with insurance, just getting into the hospital. Dealing with the system, it's become, so I've been a nurse for 40 years and my husband's a physician, so all that, I'm being transparent here. I think that the system has become more fractionated and it's really hard to work the system, especially if you don't know how to work the system. So I think that this can become part of the problem, to be honest with you. So my goal is to talk a little bit about patient empowerment, psychological aftermath, psychological sequelae, and systemic implications. What I chose to do was to find a story. So my story is about a doctor who lived in Massachusetts. He was an anesthesiologist at Mass General in the early 60s. His name was Dr. Egbert. He is my hero, and you'll hear why in just a minute. Dr. Egbert decided that he wanted to do some early pain research, pain mitigation. That was his focus. And I thought, 1964, I mean, this is so far, so long ago, people were still smoking in hospitals, as were the doctors. He decided to do a randomized controlled trial with 97 patients, all of whom were undergoing intra-abdominal surgeries. He did pre-anesthesia discussion. He conducted a discussion with the patients and gave them lots of information about what they could expect, how long the surgery would be, what time the surgery was scheduled, the fact that they would wind up in the recovery room, and sort of gave them the big picture. What he did was create two groups. One was the special care group, which I call the Nordstrom care group, and the other was the control group. And I hope it's okay to say Nordstrom's, but you know what I mean. It's like, fancy, high-end, boutique, what we would call concierge boutique and care kind of thing. These folks were in their early 50s. Most of them were around 52. They had, not everybody had had the opportunity to be exposed to any subsequent discussion about what would happen post-op. So the special care group was the group that had the specialized discussion. Prior to surgery, Dr. Egbert sat with them, talked to them about the fact that they were going to have pain, talked about the kind of pain they were going to have, what they could expect, the fact that they would have medication that they could get on demand or upon request, that there were certain activities that they could engage in that would help them mitigate the pain along with the medication. He was very good about it, very invested. I mean, this is 1964. He's a pioneer as far as I'm concerned in pain management. The control group got no discussion about how pain would be mitigated, how it would be addressed. They just knew that they would be able to have medication. So in his role, Dr. Egbert basically normalized the whole concept of post-op pain, but also told patients what they could do to help deal with it. He told them that they would be able to use a trapeze over their bed. He talked about different positions they could take that would help them become more comfortable. He talked about deep breathing, muscle relaxation. I mean, this is early. This is 53 years ago. He was very reassuring. He saw the patients post-op in the recovery room. He saw this special care group the same day again in their room. He would see them once or twice a day, reassure them that they probably would do well with all the things that they, had learned. He educated them, but that they could take medication whenever they needed it. They were pretty happy about it. He was also very positive, lots of good bedside manner. The control group, as I said, got none of that. So what happened with these patients? Kind of interesting. The results of this were that the patients who belonged to the Nordstrom's group were more comfortable. They were more proactive. The first and second day post-surgery, everybody used about the same level of narcotics. Subsequent to that, the next 5 days, the amount of medication titrated off substantially for the Nordstrom's group remained fairly consistent for the control group. They got so good at mitigating pain with additional activity, not related to medication, that they actually decreased their narcotic use by 50% and were discharged 2.7 to be exact days earlier than the control group. The control group had lots of complaints about pain, and there was a lot of agitation as to why they hadn't been instructed previously about what kind of pain they would have. One of the things that I love about this is that this was an example of patient empowerment. It's also an example of the psychological aftermath of patients that are empowered and educated and supported versus those who are just part of the system and sort of run through the system as it normally stands. In terms of the outcome, I actually really appreciated Dr. Egbert's comments. He talked about modifying his approach to patients. Anxiety is one of the major factors that causes post-op lack of mitigation of post-op pain, anxiety and depression. So he had one patient who was hysterical, and he basically wanted to sort of walk away. What he decided was that it was better to titrate the amount of information that he gave her, and didn't want to ignore her or basically abandon her, because if the patient's abandoned, he felt, then that would only magnify the whole issue of pain post-op. He also talked about, as a result of his experience with these patients, that patients who tend to avoid discussion of pain are the ones that are more challenging to address and to help after surgery is done. He talked about his reassurance as a, quote, superficial psychotherapy. Now, I don't know if this is the first evidence of psychotherapy to mitigate post-op pain, but in this article appeared in the New England Journal in 1964. I don't believe that there's a lot of discussion about psychotherapy at that time. Also, he talked about the placebo effect. He felt like they were generating through their actions a placebo effect, which I actually think was not a placebo effect. It was the effect of psychotherapy. And I think this example really helps us get a sense of what happens when providers are willing to think outside the box, which is one of the things I love. So the take home is that fast forward 53 years later, we're dealing with the same issues, unfortunately, but we're certainly light years ahead in terms of what we can provide. In terms of patient empowerment, there was education, goal setting, good coping skills, optimized locus of control, in terms of psychological sequelae, enhanced quality of life, and good cognitive and affective improvement. And in terms of systemic implications, not necessarily for this particular cohort, but the dosage of medication was lower for this group, but lower complications and faster recovery rates could be a systemic implication, as well as decreased depression and anxiety. And if we don't do these kinds of things, we can certainly have negative outcomes in terms of post-op pain management. For example, the development of chronic post-surgical pain, poor compliance issues, folks that have distrust in the system as time goes on, negative economic implications, insomnia, anhedonia, just lots of challenges. So I really do believe that Dr. Egbert is a hero. And the title of the article is Reduction of Postoperative Pain by Encouragement and Instruction of Patients, a Study of Doctor-Patient Rapport. And the last phrase, a study of doctor-patient rapport, I think is a critical issue in this big picture. Thank you very much.
So I'm going to talk about the practical aspect of using evidence-based modalities, and I'll tell you how it even came about. My own journey with pain. I was a healthy individual, and one day I found myself waking up in the hospital. I had been victim of a violent crime, and there was surgery that had to be performed on me to keep me alive. So I went from somebody who could do a lot, who was very active all day and athletic, to someone who couldn't move and needed help to go even to the bathroom. So that's where my post-op journey and their love-hate relationship with pain started. Over the course of time, as I learned to empower myself, I found myself changing from an engineer to a healthcare professional, and very much gravitated towards pain management. The tips I'm going to share is from the pre and post-op surgery class that I teach at UCSF, because we see a lot of improvement in the outcomes and just the satisfaction of people when they feel prepared, like the way Alicia talked about it. And we try to figure out a way to make that knowledge easily accessible to everybody. So we worked on building a solution, an online solution, an app that can make all of this information available and accessible to all as the first step in that direction. So the first question is, does preparing for surgery really help? If not, then why waste time, right? So there have been a lot of studies done, over 200 studies done on 8,000 patients that show that it does lead to reduction in pain and fewer complications. And one thing to note is that when we look at pain management, pain comes as a symptom cluster, which means if a person has pain, they're likely to get all other issues. They're going to have fatigue, they're going to have depression, they're going to have anxiety, and they're all going to interplay with each other. And this also is impacted by their treatment as well as their environment. So when we look at how we handle pain, we need to think about all these different aspects and addressing all of them at the same time. So in terms of where we start, the first step is actually to make a plan. And part of that is knowing what to expect with your treatment, what to expect pre, intra, and post, and even small things like who's going to drop me there, or what am I going to eat, do I have time off, results in a huge reduction in anxiety if you know what to expect and you're prepared for it. I have seen that I've had to give personally 50% less anxiety medications and pain medications when my patients are prepared for the surgery. They know what to expect because anxiety and pain correlate with one another. The other thing is, at some point, given that you're going through a surgery, it's going to be debilitating and impact us for some time. You're going to feel crappy. So it's really important to have a I feel crappy plan. So what does that mean for you? What can you do to feel good or to just get through it? And then it's easier to go through that checklist of I can handle by doing X, Y, Z. I had a couple of friends that I had on my crappy plan list. So I would SOS them saying, I'm going to call you and rant because that's what I need right now. And a pain management plan. So that is going from least invasive to most invasive. What are the options you want to consider, and then having that figured out for you. So when we talk about pain, one thing also I want us to think about is not to shy away from pain medications, because if this is short-term pain, that is post-op, pre-op, so if we are in pain, as we saw in the other picture, it's going to relate to other issues. If you can't sleep well, you cannot get your physical therapy, you feel down, it's going to lead to a longer recovery time. So let's think about if we need to use pain medications and think of what are the other ways that we can handle pain when it is before it's starting or just when it is starting. So that's when you can look at other evidence-based options. Also look at side effect management, because a lot of times when it's pain or it's surgery, it's going to result in other issues that we have, like constipation, or the digestive system is still waking up, insomnia, all kinds of other issues. And there are a lot of ways to use integrative medicine modalities to address that. So here are some options. I won't read through the entire list, but I think Alicia touched on a lot of those with the visual therapy that she talked about, as well as using exercise, and you talked about the planning for it. And there are a lot of all these modalities. I have personally tried them, and I've had a lot of our patients try them, and they're very effective. If you haven't heard of laughter yoga, you might want to check it out. So next, I want to talk from a tech perspective. So what we wanted to do was, given that there are, when it comes to integrative medicine, it's not very clear a lot of times what is safe to use and when. So we tried to package that information into an easy to use solution. So what we have done here is that you can add any symptom that you have, And then for that symptom, it'll show you modalities that are effective, that are evidence-based, and what is the research behind it. And then you can just add it to your solution, to your care plan. So for example, these are all the modalities for which there might be a solution for constipation or for pain. And these are all backed by research, and they're all available for free. So now you have the power in your own hand of what to do. Even if you're exploring what are the pain medications I can take, you can look at all those options in pharma and then go and talk to your provider about it, do research on it. If you're looking for less invasive options, like meditation or visual therapy, you can add those to your plan. If you need to look for practitioners, a lot of times as providers, we get really busy and we might not get time to refer you. Or if you feel like you need a little bit additional support, don't be afraid to get a coach, get somebody to help you out. Whether it's a physical therapist, it's a nutritionist, it's a psychotherapist, get someone on your team who will help you to get through this part. And there are lots and lots and lots of community resources. I discovered, even as a cancer clinical person, we were just talking about very few of them with our patients. But when I started working on this project, I discovered over 10,000 organizations for cancer alone that are there in all these categories. So look for the organizations that can support you for whatever is your need, whether it's transportation, it's lodging, it's grief, emotional support, whatever it is. Try and find your tribe and find people who can help you. And now I'm going to turn over to Jessie, who's going to be talking about one specific aspect, hypnosis in surgery.
Thank you, Sangeeta. So I'm Jessie. I'm an internist here at Stanford. I'm a surgical co-manager hospitalist, which I'll have to explain. So I'm an internist on the orthopedic surgery service. So I take care of the medical problems of patients who are admitted for surgery. So as such, in the first 6 months of this position, I started to encounter all of the side effects of narcotics. And as it turned out, surgery itself, anesthesia is pretty much worked out the kinks in that. So, surgery itself is fairly safe, even though it's something that people really fear. What causes a lot of harm in the hospital after surgery tends to be the way that we manage pain and narcotic side effects. And I noticed that this was a real problem. So as an internist, I thought, how might we question was, how might we as internists improve surgical outcomes in these patients? And so I started looking, I got a little curious about alternative methods of perioperative pain management, and I came across the idea of hypnosis. So I had no experience with hypnosis. I thought it was kind of a stage entertainment gimmick type thing, as many people do when I first talk about this. And I came across some research in my hunt, and I wanted to share this paper with you. I'm not going to go into the nitty-gritty detail of it because of time, but I'm happy to answer any questions if people have them after. So the clinical definition of hypnosis is really a increased internal focus, decreased peripheral awareness, and increased suggestibility. And that's pretty much the clinical phenomenon that is thought to occur during hypnosis. And so David Spiegel and his colleagues published a study in cerebral cortex last year where they used functional MRI to really discern the pathways that occur in the brain that are different during hypnosis versus when people are not hypnotized or when they're undergoing other relaxation type activities. And so without getting too detailed, there's areas of the brain that are downregulated that normally are responsible for critical judgment. When you suspend your critical judgment, if a practitioner tells you under hypnosis, you might be surprised at how comfortable you're feeling when you wake up from surgery. You might be, wondering how is it possible that you actually feel the pain, but it doesn't bother you. And you may be able to believe these things because of this downregulation of this particular area of your brain that's normally responsible for critical judgment, saying, that's impossible, I just had surgery, I have to hurt. So other regions of the brain have other activities, including your prefrontal cortex that makes a lot of your decisions, actually interacts more with your autonomic nervous system structures during hypnosis, which gives the patient the ability to change the way that their physiology responds to pain. So heart rate, anxiety level, all of the emotional, physiologic components of pain that are really inextricably linked. You can use your cognitive, volitional, I would like to feel more calm and comfortable now, to affect your autonomic nervous system, which is technology that exists in 75% of people's brains. It's built into our physiology, and it's not something that we learn about in medical school. So reading through research like this, I realized this is not a gimmick. Hypnosis is a real thing. This is incredible. Are people using this in surgery and in pre-op and post-op recovery? And so here's just a quick snippet of some of the literature that's in hypnosis for perioperative pain management. So I'll just go through the first one. This is a Lancet study, also done by David Spiegel. He's vice chair of psychiatry here at Stanford. And they were doing biopsies of patients through the skin while they were awake. So these were procedures that were under sedation, but not general anesthesia. And people had the pain button, right, the PCA, so they could administer their own pain medications if needed. And they hypnotized a group, they did sham hypnosis in a group, and they did nothing, usual care for the other group. And they found that the hypnosis group used 40% fewer narcotics in total dose compared to the other two groups. And the procedures were 17 minutes shorter, which is incredible because that translates to shorter procedures, fewer opportunities for complications, and imagine the cost savings. And so the clinical psychology review paper was a meta-analysis published in 2013. It looked at 34 randomized controlled trials using hypnosis for perioperative pain management and decreasing narcotics. Overall, they found on average a 25 to 40% reduction, similar to the Lancet study, of narcotic use. Complication rates were down, anxiety was down, and they found that it was a really effective tool overall. And so my question was, there's many other studies that I could go into, but my question was, if this is a tool that we know works, that's already in the literature, why aren't we using it? Why isn't this something that's been generalized? And I think there's a lot of reasons for that. One of them is that it's been limited to psychiatry in the past. So normally hypnosis is a tool that psychiatrists can seek out. The other reason is, hypnosis has been around for 300 years, and it's sort of a pathway you can engage someone in their own mind. And so it's really hard to monetize that. And so I think that a lot of things in medicine get pushed forward because of the opportunity for somebody to sell a product. And so this is something that, is a little bit more organic. And oftentimes those interventions don't get the attention they deserve. So, I'm here at Stanford. I thought, wow, if this is a tool that could be helping patients, we could be decreasing narcotics, decreasing narcotic side effects, potentially impacting narcotic complications, therefore impacting length of stay, total cost of a surgery, improving surgical outcomes across the board. And we definitely need more research, more randomized control trials. We have 34 that they were able to identify in the study. In 300 years, only 34 randomized control trials. We need more. And so I approached David Spiegel here at Stanford and asked him if he would mentor me in a hypnosis project as an internist. And he said, absolutely, he'd be happy to. So, I joined an organization that was able to give me the professional training in hypnosis. So I got myself trained, came back to Stanford and asked the hospital if they would develop a credentialing pathway with me so that internists could be credentialed to perform hypnosis, which was previously limited to psychiatrists. And we did that. So I went to the Department of Medicine and said, hey, do you guys mind if I run my own clinical trial? I've been attending for all of 6 months. And they said, great, awesome, do it, go for it. So I went to the Department of Orthopedics and asked them, hey, can I hypnotize your patients and see if they, do better? And they said, yeah, sure, great. If you think it'll work, go for it. So that's one of the benefits of being at a place like Stanford. So next week, I'm enrolling my first cohort in hypnosis for perioperative symptom management in elective orthopedic surgery. So we're going to do total knee replacement patients. So this is a pilot study. I'm hypnotizing 60 patients. I'm enrolling 60 patients. 30 will undergo hypnosis, 30 will undergo usual care. And so the hypnosis group will have the same access to narcotics, the same access to all of the pain consult teams. Everyone on the treatment team will be blinded to this intervention, the hospitalist, the surgeons, the anesthesiologist, the pain team. I'll be the only person who will know whether these patients are being hypnotized or not, and I'm not going to be taking care of these individuals while they're hospitalized. And what we're going to be looking at are narcotic use both in the index hospital stay while they're getting their surgery, but also post-op out to a year to see if we can impact the 2-week, 6-week, 3-month, and and year, 12-month narcotic use for these patients who oftentimes end up using narcotics for quite a while. We're going to be looking at complication rates. We're going to be looking at pain function, anxiety scores, activity levels on the patient side. And then we're going to be looking at the things that the healthcare system cares the most about and can really get attention when you're trying to generalize something new that might sound a little quirky, which is length of stay, total cost, readmission rates, these types of things. And so, if we can get good results with this study, the plan would be to generalize to other surgical populations at Stanford, and then to go on and work with some of the medical populations here as well. And then, of course, beyond to multi-center trials and hopefully generalize this nationwide, which I think, internists are many. We are plenty, and we are everywhere. We take care of every kind of patient. And so I think that, being an internist and bringing this, perioperative preparation and this novel non-pharmacologic tool is a unique position. And so I hope to be able to bring this into the limelight. Thank you.
I don't have any slides here, so I'll just sort of respond to the panelists before. And of course, everyone's heard of laughing yoga. I see it every time I do yoga. Everyone else in the class laughs at me. So that I'm sure does wonders for me. What's interesting about this panel is the contribution that's being made today that I don't think is well known around the country. So we know, I don't have a citation for this, so it needs to be double checked. But the study that I read most recently indicated that out of every 16 prescriptions, that one of those 16 ends up in an addiction to opioids. And if you heard my talk this morning, we know 64,000 people died of overdoses of opioids last year. So the degree that we can reduce the number of people that leave the hospital with a big opioid prescription will definitely translate into lives saved. And that in itself, we just stop and do more of it. But if we think about the other messages that I'm hearing as well, we sort of missed one piece, is the quality of life for individuals going home. So the patients and their families have a much easier time in the recovery phase. And as an economist, I go straight to how much money can we save on this? And so I think about where are we on making the results of this translate into policy? And there's a much deeper discussion about what's the proper role of government into explaining to the health system about what to do for prescriptions and procedures. And happily, we don't have a big role in doing that. But what is interesting is the number of initiatives that we put out from the government that involve payment policy and demonstrations. So you could imagine that with more bundled payments and the results of your study, it becomes very easy for advanced and progressive health systems to think this through and say, yeah, of course, we'll use another method to reduce overall costs, send people out. They have a much better impression of their hospital stay, so our hospital does better in surveys, CAP surveys, et cetera, and they save money. So I think what we're seeing is the type of work that should get more attention. It should get more attention within the government just to be tracking this as well. It can help maybe inform those grant makers, whether it's in NIH, AHRQ, and others, to keep their eyes on this or provide funding for this. And then for those in the community that are really focused on reducing opioid deaths, is to go upstream. So if we reduce properly the number of opioid prescriptions, we know we'll reduce the number of deaths at the end of the day. So I feel very privileged to be able to learn from the panel today. I'm very, very happy to be here. And I wish everyone best of luck in moving forward and putting these programs into place. Thanks.
Happy to take any questions. I know we are also in between your lunch, so we are here for a few minutes if you have questions. Otherwise, enjoy your lunch. Thank you for joining us.